Hello, I'm Richard Sullivan. I'm a professor at King's College London in the King's Health Partners Integrated Cancer Centre, and the area I specialise in is oncopolicy, so social and political policy of cancer, which is a joint initiative with the European Institute of Oncology in Milan. The issue of the elderly cancer patient is one that's been with us for 20 years, and it's actually a huge public health issue. Something like a third of the population across Europe is going to be over 65 by the year 2025. And when you think that nearly 70% of cancers occur in the plus 65-year-old age group, in numerical terms, this is essentially a tsunami heading towards Europe. Some of the policy research that we've been conducting with the literature review indicates that actually people are using too easily and too freely chronological age as some sort of surrogate for biological frailty. And it's quite clear, actually, from all the evidence that it simply is not true. That actually within the elderly population, we're talking above 65 years old here, there are actually a huge spectrum. There are very, very fit elderly individuals who are not getting access to the best treatments because essentially they're being down as frail based on their chronological age. We know from the literature review that in the solid cancers, particularly breast and lung cancer, for example, there's a lot of ageism in terms of offering the new targeted therapies to those patients. Today, we've had presentations from Jan Geisler, new data from Germany showing that in chronic myeloid leukemia, if you're around the age of 40 and below, 93% of those patients, whether you're a man or a woman, are getting access to cutting-edge gold standard treatments. But by the time you reach 70, 75, that's dropped to between 40 and 23%. And there is absolutely no clinical reason why that should occur. This is purely discrimination based on age. A lot of research on ageism has shown that actually we've got, firstly, a societal problem with age. We've had an inversion in attitudes, whereas once upon a time, age was considered senior and respectful. Because individuals now have a retirement age and they're no longer, in inverted commas, economically worthwhile, there's a great deal of ageism that's crept into developed society. So that's one problem. But then when you dissect it down to the healthcare profession, the ageism that's creeped in there really has been ingrained through education, which has always said chronological age can be used as a surrogate for frailty, and that simply isn't the case anymore. King's Health Partners and European Institute of Oncology, together with other partners, is putting together an initiative which is trying to push up the agenda, the social policy agenda of cancer and the elderly. This is an agenda item which has actually been around for 20 years, and luminaries like Matti Apra, and Professor Belladucci, and Professor Ian Fenterman at King's College have been trying to bang the drum for 20 years. And they've been voices in the wilderness, and what we're trying to do is drive behind them evidence-based policy making to really push this to the top of the socio-political agenda from both patients and civil society and governments. Evidence-based policy making essentially says that opinions carry a lot of weight, clearly, but people need hard facts these days. They need hard economic analysis. They need analysis of socio-cultural views. And we use experts in lots of different areas: evolutionary psychology, cultural transmission and social science, health economics, and we pull these expertise together to provide hard data and evidence to policymakers on what the suitable courses of action could be towards dealing with the cancer and the elderly. And it's this sort of evidence-based policy making that really can push the agenda. The first point to make about the ageing population is we have to stop thinking that somehow 60, 65 is no longer economically viable. The fact is fertility rates are crashing. We don't have enough young people around. And actually, 65, 70 is the new middle age now. Individuals are economically worthwhile. They are being productive for society, either directly through employment or in terms of supporting families, the grandmother effect, where uncle and aunt and the elder members of the family are looking after and helping to look after the children. And it's that sort of intrinsic economic value that you can derive new models to demonstrate that treating those populations with cutting-edge treatments isn't, in inverted commas, wasting money. That what you're trying to do is make those individuals survivors. Because if they're survivors, they can then input back into the economy and into the general social fabric of society. The demographic changes to our populations globally are absolutely astonishing. The classical pyramidal structure, a lot of children at the bottom, very few elderly tapering off to the top, is being completely inverted as fertility rates go down and down. And as we increase longevity, there is no end in sight for how old populations are becoming. And this is not just for developed countries. India, China and Brazil, the three biggest countries in terms of populations, are also seeing at an even faster rate their societies age as well. The key messages are firstly that ageism in cancer should be outlawed completely, that this is about the biology of the cancer and the biology of the patients. It's not about the chronology in age. And secondly, there needs to be a lot more focus on the issues surrounding the social policy of patients, both during the treatment phase and also as survivors in terms of social support for in the environment, and also social support for those individuals who are most vulnerable.